Well, it is 8 o'clock and we're going to go ahead and get started. I want to welcome you to the February ABIN webinar. We are so glad you're here and spending this time with us this morning. I want to remind you that we are recording today's webinar, and by staying on, you're giving us your permission to be recorded. This recording will be posted to the ABIN website as well as the slides. And so if you're interested in referencing that after the webinar, please don't hesitate to hop on there. I just have one quick announcement. Well, actually two. Wanted to let you all know our March webinar, we will be having our MSW students, and they'll be sharing their experience working in primary care clinics in a PCBH model of integration. So we're excited to hear from them and looking forward to hearing about their experiences. But the big announcement is we do have our ABIN webinar. That will be April 8th, Tuesday, April 8th at the St. Vincent Center. That will be free and it will be from 8 to 4:30. I think we're giving 7.5 CEUs. Don't quote me on that. It might be 7, it might be 8, somewhere in the 7 to 8 range. I haven't looked at the flyer again, but want to remind you, you're not going to want to miss it. These our wonderful speakers today are going to be there in person, and so it's going to be phenomenal. With that, I'm going to pause and hand it over to Dr. Gibson to introduce our speakers for today.
Good morning. I'm really happy to get to be here today and to introduce Dr. Apiagyei and Dr. Onawa. I have had the great opportunity to work in medicine a long time. This morning, I actually had to get the calculator out to figure out when I graduated medical school 40 years ago, and so most of y'all are not even that old. But the reason I'm saying that is I've had an opportunity to do several different types of medicine and different settings. And the type of care that I personally have enjoyed and gotten the most out of was when I had the opportunity at the VA in 2009, 10, up through 17 to work in primary care. And so get to work with a primary care team at the VA, hand in hand with primary care doctors, mental health doctors, but also we had a team of 10 that included psychologists, therapists, social workers, and nurses. So we had a range of work. And when I most think about my personal work, I remember patients and interactions that I had with staff while I was working in primary care. So that's the thing that really keeps me going, and knowing that integrated behavioral health is such a rewarding practice, not only for the clinicians that get to do it from the mental health side, but also the primary care clinicians and the whole staff. And I know it really makes a difference for patients that we can take care of. And so around 2018, I began to really earnestly try to get to know psychiatrists who were interested in doing integrated care. And there's actually not that many of us that have the opportunity to do it. But recently we met Dr. Cyril and Dr. Jason, and I'm really happy to get to bring them to Arkansas. I'm impressed with them as individual people and their passions and their values, but also their work passion and what they're trying to do in their practices. So really glad that we get to have them today, but also have them working in Arkansas, and they'll be talking about their work. So just to take a minute and introduce them, Dr. Cyril Piaget is a psychiatrist and the co-founder of Woven Clinics, which focuses on behavioral health integration. His passion for mental health care began early, shaped by his experiences working at his parents' primary care clinic on the south side of Chicago. While attending medical school at the University of Minnesota, Dr. Piaget gained invaluable experience, primarily working at the Safety Net Hospital and serving as class president. His leadership continued during his tenure as outpatient chief resident at Northwestern Memorial Hospital, where he focused on enhancing both patient and provider experiences. In addition to his clinical work, Dr. Piaget was selected as an American Psychiatric Association Leadership Fellow during his residency. a role that has strengthened his administrative and policy expertise intending to improve mental health care systems. Dr. Jason Onawa is MD, MPH, is a compassionate psychiatrist with a profound commitment to serving underserved populations and advancing public health initiatives. He earned his undergraduate degree in anthropology. I wish I'd been able to do that from Washington University in St. Louis in 2014, followed by an MD, MPH from the University of Miami Miller School of Medicine in 2020. He completed his psychiatry residency at Northwestern University in 2024, where he met Dr. Cyril and where he received specialized training in collaborative care models, COCM. This is a testament to his dedication to integrated population level mental health care. Jason's journey in public health began in medical school, where under the mentorship of Hansel Tooks, MD, MPH, he co-founded a student-run clinic providing essential care for people who inject drugs. This initiative, coupled with his advocacy for the Infectious Disease Elimination Act in Florida, ignited his passion for psychiatry and highlighted the critical importance of harm reduction in improving community health outcomes. So I wanted to take time to read their real bios because it's just packed full, and I appreciate them being here and for us to have the opportunity to work with them. So you see they're highly qualified, but also just really great people. So thank you for being here. And Dr. Jason, Dr. Cyril will let you take it from here.
Wow. Good morning, everyone. First off, I would just like to start off by saying thank you so much for that wonderful introduction, Dr. Gibson. Since meeting you all at ABIN, it's really been a truly humbling and inspiring experience to learn from you all, to collaborate with you all, and to better understand and honestly become part of the work you all are doing in Arkansas, which has definitely become a vital part of our story and our journey. And then hi to everyone else that doesn't know us. It was a great, wonderful introduction. We'll start off by just kind of jumping right into it. If folks have questions throughout the presentation, please feel free to either stop us or post them in the chat, and I'll try to keep attention to it. But maybe Dr. Gibson or Kim, if I miss it, please don't hesitate to let us know. Today's presentation is called Bridging Practice and Policy, Woven Clinic's Journey in the Behavioral Health Integration Space. And we are going to talk about exactly that. We're going to talk about kind of our background stories, how we got to this place, and the work that we're doing in collaborative care, especially in Illinois, as well as how that relates to the things that we are doing here in Arkansas as well. All right.
And I'll just also start by saying good morning, everyone. Thank you for sharing your mornings with us. I know we're all busy, so I appreciate that you're here. We're honored that you're here, and it's a pleasure for us to be here as well. And then we'll just jump into, our mission and our vision. So as mental health providers, we stand at a crucial intersection where we feel our traditional expertise meets contemporary advancements in mental health care. I'll let other people read the chat. At Woven, our goal is not to replace, but to integrate seamlessly and embed modern evidence-based treatments into existing healthcare systems. And why? Well, because we think integration allows us to heal individuals more effectively, ensuring that patients receive comprehensive and personalized, sort of tailored care to their unique needs. But beyond individual healing, our approach also aims to enhance community well-being, recognizing that mental health is deeply interconnected with broader social and healthcare structures. At the heart of this model is collaboration. We don't work in isolation. We interweave ourselves with existing mental health providers. The goals of strengthening the care that's already being delivered. We want to create a system that is not just effective, but I think really truly empowering for patients, but really also for our colleagues and for the mental health field as a whole. We think this is the future of mental health care, right? Integrated, collaborative, and deeply personalized. So, our learning objectives, right? So some of the things we're hoping to cover. Today, we'll explore how mental health specialists, like many of us here, are uniquely positioned to drive change, advocate for systemic improvements, and help expand integrative mental health care models like the collaborative care model. For us, being early care physicians, recently out of rigorous training is a source of motivation. We have some newer perspectives that are adaptable and a deep passion for improving mental health care. We've trained in an era of evolving technology, emerging therapies, and shifting healthcare models, maybe giving us a different perspective on how we view and create new approaches. And we are focused on integrating evidence-based behavioral health solutions into existing care frameworks. We want to bridge the gap between, again, the traditional and the innovative, adding that team-based approach, prioritizing accessibility and comprehensive care. And today we hope that you all will learn how clinicians through these approaches can contribute to the development and expansion of integrative models, right? We also hope to show how Woven clinics leverage the position of its early career psychiatrists to advocate for systemic changes, particularly in the adoption of COCM. And we will share strategies that we use to navigate barriers to the adoption of this model, drawing from our advocacy work in Illinois. We also hope to emphasize that engaging with policymakers and healthcare leaders can lead to significant changes in healthcare practices and policies, and that clinicians can effectively contribute to these discussions. An important part of today's talk will also be to reflect on the common challenges faced by people, clinicians, when building and advocating for new healthcare models. And we will explore how these changes can be transformed into opportunities for both personal and professional growth. This is where I think advocacy becomes crucial. As clinicians, our role allows us to not only provide clinical care, but also amplify the voices of our patients and colleagues. And we can go next slide. So, our bios were already sort of read off, but just to expand a little bit on them. So I was initially born in Ghana, West Africa, and actually came to the US because my dad is a med-peds trained physician, did his residency in New Jersey, and then actually lived in a small, with the family, a small rural town in Maine, Norridgewock, Maine, about 4,000 people. Worked there for a little bit before deciding to move to the south side of Chicago. And Patty mentioned, the clinical work my parents have done, and they've had these two primary care clinics. And I think, being forced to work there some summers when I'd rather have been at home playing video games, some of the things, I learned a lot of different things, but I think, some of the things that definitely came up was the lack of access to mental health care. And to the point where my mother actually just recently got her doctorate of nursing and actually is specializing in, sort of mental health care, because they need those services. But of course, this is one of those situations I think we all know it's going to be very different to sort of train ourselves out of, right? Just with the growing demand and need and the lack of sort of providers. So I think that's something that we've all been kind of struggling with and thinking about how can we approach this differently. And in residency, when I'm training, I think a lot of what our colleagues have done is they either do fellowship and work for large academic institutions, or they go into private practice and they, accept either really good insurance or, cash only, and, they provide great care. But I think, and I'll let Jason expand a little bit on his bio. We really wanted to find a way to see if we could be a part of solving any of these problems with lack of access.
Yeah, 100%. And, a little bit about my background. I was born, raised in Florida, and I ultimately attended medical school there and did a master's in public health program. And it was during that time that I had the opportunity to work with folks amidst the opioid, epidemic, and people who were injecting drugs and the overdose crisis. And I was really able to merge the relationship between clinical work and policy. You kind of saw how folks were suffering when you were working with them directly, and the challenges that they were facing and the limitations that you had when you were working with them, because there were so many issues from a systemic standpoint, from being able to access life-saving interventions, that you really had to step away from the work that you're doing and bring it with you to be able to advocate for policy change and really make a difference. And I really had the opportunity there at that time to go to Tallahassee with my mentor, had the opportunity to present to the legislature there and really talk about the things that we were working on, things that would really make a difference in addressing the opioid epidemic and the overdose epidemic that we were seeing. So that work really started to inform my desire to think about how is it that I'm going to practice going forward? What does it mean to be a physician? The work that we do at the bedside in addressing suffering is key, right? But then on top of that, being able to take that work and advocate for our patients is another form of care. So I was in residency, and Cyril and I met on our interview days at Northwestern, not knowing that we were going to be on this journey together. But throughout those 4 years, we started just having conversations about the state of medicine, about the state of mental health care, about the fact that as we practice, we continue to see symptoms of underlying issues within the way that we manage and address healthcare. And we really decided to move forward with Woven Clinics, which we will dive further into. But we really want to think about how could we integrate models of care? How could we utilize our expertise to help people get access to really important and transformative treatments?
So, like Jason was saying, while training at Northwestern, we basically kept running into the same issue, right? People weren't getting the care they needed until it was too late, if at all. And we saw patients arriving in the emergency department in crisis simply because they really couldn't access outpatient mental health care. Others were admitted to the inpatient unit after, months or even years of struggling on their own. But even in the outpatient setting, we realized that there were simply not enough psychiatrists to meet demands, no matter how many patients we saw. It really just never felt like it was enough. You can go to the next slide. Thank you. So, like many providers, our firsthand experience with the mental health system has given us unique perspective on how it can improve, right? So throughout our time, both in sort of bedside care as chief residents, we really gained invaluable insights into the systemic challenges facing mental health care. Working directly with patients in these different settings, the emergency department, inpatient unit, outpatient setting, we saw, and felt the frustrations, delays, and efficiencies that left many without the care they needed. And our administrative role as chief residents also allowed us to have a broader view of the system, right? It really had to balance both sort of like patient care, hospital policies, resident education, which allowed us to see the gaps in coordination, accessibility, resource allocation that often led to these poor outcomes. And these, experience kind of reinforced what we had already suspected. And yeah, that's why we founded Woven Clinics, right? This desire to sort of break away from the limitations of traditional psychiatry, instead of relying solely on individual appointments with psychiatrists, which I think I speak for Jason, that we actually both enjoy that work, but we really did want to, try and build a collaborative system that integrates psychiatry with other providers and community-based care models. We wanted to make mental health care more accessible, more effective, really just proactive, so that people don't have to wait until they're in crisis to get help. 9.8 million residents live in one of Illinois' 221 designated mental health professional shortage areas, and rural counties face severe shortages with an average of, I think, 1.2 psychiatrists per 100,000 residents, compared to the average statewide, which is like 10.5 psychiatrists per 100,000 residents. But even that is inadequate, because I think technically to meet demand, the recommended number anywhere would be 25.9 psychiatrists per 100,000 residents. So in rural counties, it's 1.2 to 25.9, and then no, it's 1.2, but then it would be preferably 25.9, and then even statewide average is 10.5. Again, the desire being 25.9 psychiatrists per 100,000. So really, at Woven, our goal is simple, right? Decrease barriers to care, ensure that mental health services are integrated into everyday healthcare so that people receive treatment before they reach a breaking point. And we want to do this by rethinking how psychiatry, mental health care is delivered. And we believe we can help reduce mental illness rates, prevent hospitalizations, and the ultimate goal would be to, save lives. So choosing the collaborative care model. Perhaps especially in psychiatric circles, COCM is not as robustly known or as utilized as it could be. We were fortunate to train in the collaborative care model during our residencies, which isn't necessarily a common thing. And despite being in a large academic health system with ample resources, I think we still often struggle to secure timely mental health appointments for our patients. And this was the motivation for the administration at large to sort of try and implement the collaborative care model. For us, training in this model and collaborating with various psychiatric providers revealed, diverse approaches to psychiatric consultation, and we got to witness firsthand how effective this model was, which has been really important in not only getting patients treatment, but ensuring they receive high quality care. There are over 80, 90, maybe even 100 at this point, sort of like randomized controlled trials demonstrating the effectiveness of the collaborative care model, particularly in treating like depression and anxiety. And a comprehensive analysis of many of these studies found that patients receiving care through this model consistently experience better short-term and long-term outcomes compared to traditional care. These benefits include improved access to mental health services, reduced symptom severity, and higher patient satisfaction. And something that we don't always emphasize enough, but I think higher provider satisfaction as well, right? The strength of this research has led to, national recognition as an evidence that COCM can be an evidence-based practice. The Centers for Medicare and Medicaid Services and the Substance Abuse and Mental Health Services Administration have endorsed this model due to its proven success. So the question is, what does this data tells us? Well, to me, I think it tells us that collaborative care isn't just a theory. It's a practice grounded in extensive research, delivering real results for patients in a variety of healthcare settings. In 2017, CMS actually recognized the value of COCM, I think, by introducing the current procedural terminology, aka CPT codes, to reimburse these services. These codes are designed to capture or to attempt to capture the collaborative efforts of primary care providers, behavioral health managers, and psychiatric consultants working together to deliver comprehensive patient care. These billing codes have been instrumental in promoting the adoption of COCM by offering a clear reimbursement pathway, though I think there's still more work that needs to be done in how much is necessarily reimbursed, but for, the integrated behavioral health services. And 2018, Illinois mandated that all payers must cover these codes in the state of Illinois, showing that they recognized the importance of this model. And the American Psychiatric Association has developed model legislation to encourage private insurers to reimburse these collaborative care billing codes. This initiative aims, I think, increase access to mental health care by ensuring providers are compensated for delivering integrated services. Basically, like we need to make sure we support these integrated services financially to make sure they can be self-sustaining, right? But, other organizations such as the American Medical Association and the American Academy of Family Physicians have voiced strong support for policies that bolster COCM. And I think in conclusion for us, the reason we settled on COCM is, the establishment of specific CPT codes, sort of the backing of prominent medical organizations that have been pivotal to advancing the model. And these policies not only really support healthcare providers in delivering this care, but also enhance patient access, and thus the image of the scale, just sort of the weight of the evidence in our experience with it. So what is COCM? We've talked a lot about it. I'm sure many of you here know about it, but not everyone necessarily does. So we just want to go through the model. But I think the idea that is that in primary care settings who really see the most mental health of everyone, around 50% of individuals with mental health disorders are identified correctly as having a disorder. And of those, about 12.5% maybe receive adequate treatment, which could be related to, people not following up with referrals or being lost to follow-up. But research has shown that in COCM, where it's sort of already interwoven into primary care, 75% of patients receive a diagnosis and begin treatment within 6 months compared to, say, fewer than 25% in our traditional framework right now. So how does it work? At the heart of COCM, and truly maybe the most important piece, is the behavioral healthcare manager, or BHCM. And this individual is usually a master's level clinician, but that's not necessary. But when a primary care provider refers a patient to COCM, the BHCM, the behavioral healthcare manager, BHCM, conducts a comprehensive initial evaluation, assessing the patient's mental health needs and collaborating with the consulting psychiatrist. But the BHCM role doesn't really stop there, right? They manage a patient registry, ensuring that those who need frequent follow-ups receive timely reviews after consulting with the psychiatrist. The BHCM then communicates a clear and structured treatment plan back to the primary care provider who implements it with the patient. The registry is just a tool that allows the BHCM, the psychiatrist, to really track all the patients on their caseload, see where their scores are, PHQ-9, GAD-7, see who's been lost to follow-up, see if there's any safety concerns or there's any follow-up that's needed. But beyond coordination, the BHCM plays an active role in care delivery. They provide, evidence-based therapy such as problem-solving therapy, motivational interviewing, behavioral activation. They can help offer psychosocial supports. They're often more aware of the community resources than, say, the psychiatrist or the PCP. And they can help in conducting sort of follow-ups and coordinating specialty care when needed. And this hands-on, high-touch approach ensures patients receive sort of continuous personalized care. But I think what's even more remarkable is that COCM not only improves mental health and physical outcomes, but does so with little to no net cost over time in primary care settings. There have been some studies that have really even suggested that COCM could result in significant cost savings. And one example of this is Blue Cross Blue Shield of Michigan, I think, implemented COCM across 190 clinics, and the results, were pretty striking. The patients in the program achieved depression remission far sooner than they would have in the traditional care. I think it was 16 weeks to 52 weeks. Even more compelling, the projected medical costs for those patients, those individuals, decreased by 2 to 3 times what was expected within 3 years. So I'd say there are 3 really main benefits to COCM, which is, it works for decreasing symptom severity, increasing access, and then also the cost savings, right? So in terms of access, COCM has been shown to be effective in a variety of settings. There was a study showing that it significantly improved support for women in obstetrics and gynecology clinics in terms of depression and overall functioning. And especially in settings where women face, severe social disadvantages, just because, again, it was already kind of interwoven into the OB/GYN clinics, and they were able to meet patients where they were, ensuring, they received the care they needed without the added burden of another appointment and external referral. There was a study for African American patients that showed that COCM was just as effective as traditional care over an 18-month period, showing that this model delivered, equitable treatment. Similarly, for Hispanic patients managing both diabetes and depression, COCM was shown to lead to significantly better depression outcomes compared to enhanced usual care. And COCM treatment in these studies, again, ensure that mental health treatment is not an afterthought. It's just part of the comprehensive whole person care. And the rural communities have actually really benefited tremendously from COCM. And in federally qualified health centers, COCM has been shown to improve remission rates for patients with depression, again, demonstrating its effectiveness in areas with limited access to specialty mental health providers. And, there's also a lot of data showing good support for older adults as well. And there are private groups right now investing heavily in COCM to actually attempt to treat our aging population as well. But, beyond its clinical outcomes, COCM also improves access to mental health care in another meaningful way. And that's by embedding its services in settings where patients already receive care, it allows for sort of earlier detection, again, focusing on that proactiveness and earlier detection and intervention for mental health concerns. The proactive approach, I think, increases screening rates, ensures that more patients are identified and supported sooner rather than later. I think, other integrated models of care can also do this. I do think the advantage for COCM is its scalability. Another key benefit I'd say of COCM is its team-based structure, which reduces the needs for external referrals, and I think also allows for less information to be lost when different providers are communicating with each other. Also, instead of, sending patients to a separate mental health specialist, where these wait times are 6 months or longer in certain areas, there's transportation challenges, there's difficulties with stigma. I think the care team already being in a place where an individual is comfortable with helps engagement. I'd also say again, and I'd mentioned this I think earlier, but one of the most important advantages of COCM is its ability to reduce hesitation people may feel about seeking mental health care and just normalizing it. Then I'll jump a little bit into the financial benefits of COCM, and I know it seems like we're already halfway through, so I'm going to try and speed things up a bit. But in terms of, reducing costs, if you look at the numbers, the financial case for COCM, I think, is undeniable. There's a study that showed for every dollar put in, it'd be $6.50 of total, medical cost savings. That's a pretty hefty return on investment that I think not many things in healthcare can claim. I think one of the most compelling benefits is the ability to just lower overall healthcare costs by addressing mental health concerns early and within the primary care setting. COCM reduces the need for expensive specialty care, decreases hospitalizations, and minimizes costly emergency room visits. So again, not waiting until a crisis occurs, and just promoting the efficient use of healthcare resources by embedding into the mental health services into the primary care also just reduces costs, and again helps avoid some of those traditional bottlenecks of the patients being referred out and long, sort of waiting times. And then, I would also just add that there was a study that estimated that providing COCM services to all Medicaid beneficiaries diagnosed with depression, about 20% of the Medicaid population, could result in a nationwide savings of $15 billion. And then I'll add on top of that again, the scalability of COCM is, I think, what's so important, right? Just the fact that, again, we're not going to be able to train ourselves necessarily out of this need that people are experiencing. So we have all this information, we see all these benefits, we know all these things about COCM, but when Woven as a group, we're trying to, look for organizations to partner with in Illinois, we didn't really find many. And we actually found eventually during our research that the COCM code for, say, first time visiting COCM was billed only 956 times in 2023. We had heard, from many experts in the field that models like COCM would be necessary for the field of mental health care. We had all seen with our own eyes, the evidence of how it can work. There exists a plethora of data to support it. However, none of the medical professional organizations in Illinois knew of groups utilizing COCM that were not large, sort of well-established academic health centers. The FQHCs we approached had little familiarity with the model. As many of you well understand, had their plates pretty full, which made, considering a new model difficult. And Illinois, like, many states, again, is facing a healthcare workforce shortage. And we were thinking, like, COCM could be a part of solving this problem. But despite its proven success, COCM remains significantly underutilized in Illinois, sort of years after passing the Illinois Bill SB 2085, which required payers to reimburse CPT codes for COCM. So the question is, what is holding us back? Why has this model, with all its benefits, struggled to gain traction? The next question for us as early career clinicians wanting to practice COCM was, what do we do next? And this really necessitated us to shift our focus from purely sort of like clinical work to being investigators and advocates. This also meant we would have to look, outside of Illinois and see what other states are doing. And Dr. Anua will expand more on that.
All right. Yeah. Thank you, Cyril, for giving us, walking us through the background of how we got to this point and, the excitement that we had around collaborative care, and then recognizing as we finished residency, when we started Woven, and we're like, we are ready to jump in and practice psychiatric consulting to the collaborative care model, that we ran into challenges finding opportunities to do so. So what happened next? We recognized the need to deepen our engagement with the collaborative care model. And facing challenges getting started in Illinois, as I mentioned, we expanded our horizons to gain necessary experience and knowledge. By connecting with leaders across states like Michigan, New York, here in Arkansas with the team at ABIN, we were able to see where COCM had been actively pursued as a means to improve quality and access to mental health care. We learned valuable lessons on adaptation and implementation that are sensitive and contextual to the needs of individual communities and states. So after gaining this broader perspective, what did we do? We came back to Illinois and we were determined. We started by focusing and understanding the historical context and current state of COCM within our state. We did extensive research. We talked to stakeholders across different organizations throughout the state to get a better understanding and grasp of the situation. The insights we gathered were really instrumental for us. From there, we were able to think about a strategic plan which would address potential benefits as well as substantial barriers, from systemic silos all the way to financial and regulatory hurdles for us to get COCM off the ground in the state. We translated these insights into a detailed policy brief aimed at educating and persuading stakeholders in the state about the advantage of COCM. The brief that we made highlighted the clinical, economic, and accessibility benefits COCM offers, serving as a key tool in advocacy efforts for policymakers, healthcare providers, and payers. So now that we have this robust strategy and comprehensive documentation, our focus shifted towards coalition building, engaging with diverse stakeholders, including healthcare professionals, state reps, and community leaders, has really been a crucial part of the work that we're doing. These collaborations aim to really focus on fostering a unified approach so that we can move forward in the development and implementation of collaborative care. So now our ongoing efforts are focused on educational initiatives to raise awareness about COCM and developing, hopefully, pilot programs within the state to showcase its real-world effectiveness. Each step is geared towards creating a substantial and sustainable model, ensuring comprehensive and integrated mental health care throughout the state of Illinois. As we continue the groundwork, we have laid helpful blueprints for us to think about how we're going to go about building this program throughout the state of Illinois. So it really we got to this point where we didn't know how to find partners to do this work, and we had to better understand what the challenges were and why that this model wasn't widely adopted. So we started doing all that research and getting that background information. So now let's take a closer look at really what we did in terms of developing, these models. In advancing COCM, we embarked on a multifaceted approach that began with a comprehensive analysis of the state's healthcare landscape, right? This analysis helped us understand the depth and breadth of the existing infrastructure, the distribution of resources, and the specific needs of diverse communities throughout the state. The findings were crucial in shaping our strategies and informing the direction of our initiatives. We identified several significant barriers to COCM adoption, which included regulatory hurdles, financial constraints, and a lack of adequate training and support for healthcare professionals. Each of these barriers required tailored strategies to ensure that the integration of COCM could be both effective and sustainable. Addressing these obstacles involved advocating for policy changes, collaborating with insurance providers to improve reimbursement models, and developing robust training programs for healthcare teams. Among our major initiatives was the development of the strategic plan for COCM adoption, which laid out a detailed roadmap for expanding the collaborative care model throughout the state. This plan included specific goals and objectives aimed at integrating mental health services with primary care settings more effectively. It proposed structured approaches to implementation that included development of pilot programs and the establishment of a centralized oversight body to coordinate efforts across the state. The Illinois Policy Brief, another significant initiative, was developed to educate policymakers, healthcare providers about the work of COCM. The brief really underscored the evidence again and tried to highlight how we could go about in a stepwise fashion, creating more programs and making this a hallmark of the mental health care access. So together, these documents and the strategies that we outlined really guiding our efforts, building a stronger, more integrated healthcare system. Through these strategic initiatives, we at Woven Clinics are not just addressing immediate needs, but really thinking about how we can pave the way for a long-term solution to the challenges that we face within the communities. All right. So now that we work to create these outline plans, the strategic plan, the policy brief, we were really starting to engage with folks about these issues there, we took some next steps. So to take those next steps, it was really crucial for us to acknowledge the groundwork laid by, established organizations such as the Illinois Psychiatric Society, the the Academy of Family Physicians there in Illinois, that were really working to focus and develop COCM programs. IPS, the Illinois Psychiatric Society, they have long been advocates for the advancement of COCM in the state. Just last year, they introduced a bill aimed at developing a grant program to address the financial challenges of starting new COCM programs. While that bill was ultimately unsuccessful, it has not deterred their efforts or ours. We're working alongside the Illinois Psychiatric Societies as they continue to build a coalition aimed at moving the mission of behavioral health integration forward. Their efforts combined with ours are central to engaging primary care groups and key stakeholders, creating a unified front to advocate for necessary changes and innovations in mental health care delivery. So the importance of coalition building extends beyond merely participating in discussions. It involves making a seat for ourselves at the table. It's about ensuring that our voice, representing both our patients and the communities we serve, are heard. Being present and active in these coalitions underscores our commitment as advocates for integrated care and highlights our role in driving change. Through these partnerships, we are not just participants, but active contributors in shaping the future of mental health care in Illinois. Together, we aim to overcome barriers and find innovative ways to improve access outcomes for all patients across the state. Ultimately, our goal is to ensure that every step that we take towards integrating COCM is informed by deep understanding of the needs of those we serve. By making our presence known and our voices heard, we champion the cause of mental health care, advocating for a system that truly supports and enhances the well-being of communities. All right, next slide. So, as we are getting to the conclusion of this presentation, I really wanted to kind of transition and literally talk about how people could take action and what you could take from our story, especially here in the state of Arkansas. It really has been a pleasure working with the Arkansas Behavioral Health Integration Network. Kim and Dr. Gibson are really forces of nature. The work that they're doing here in coordination with UAMS, who has really been a strong proponent of collaborative care here in the state of Arkansas. When we found that, hey, we're having a trouble finding opportunities to practice clinically in the collaborative care model in our state, we said, let's look outside of the state. Let's look to national organizations. Let's look to understand what other states are doing and being able to work with ABIN and ultimately provide psychiatric consulting in the collaborative care model with East Arkansas Family Health Center and Dr. Ward Jones and the work that they're doing there really reflects some of the things that we're taking back to Illinois, right? Which is coalition building, which is having conversations in your own organizations and with your state leaders to think about how can we get more access to mental health care? How do we change the numbers, right? And I think Cyril really highlighted one of the things that sticks out to me the most about the collaborative care model is how it leverages team dynamics and is able to multiply the reach that we have and meet people where they're at. So with that being said, the things that I would say really stick out to me in terms of things that people can do are sparking conversations, really engaging in that advocacy work and pushing for policy reform, because understanding, as clinicians, the unique work that you do with patients one-on-one, the suffering that we witness in our community, we need to take those experiences and be able to convey them in a way that allows us to advocate for change. And I think that is almost the end of our presentation. And we really just think about kind of how growth and scalability of collaborative care, again, is one of those mainstays. All right. Any questions that come up, and how can we answer that? Or comments?
I was going to say typically our group is not too shy, so I'm hoping that people who are on today and might have questions about COCM, or if they're considering starting COCM in their clinic, this is a great time to ask. We have two people on who have lots of experience doing this, and it sounds like you've also seen how effective it could be and some of the struggles in getting it started. So we would love you all to ask your questions to Dr. Jason and Dr. Cyril.
I have a question, a couple of questions maybe. How have you gone about at the state level of conquering those challenges that you have to go through, all the different steps? And then another question is, how have you worked with primary care? Like, I know there's, some challenges for buy-in and just different, challenges being in the healthcare field, and that's not really your specialty. And then you've got the cost and all of that. And so can you talk about some of the challenges that you've been able to overcome and how you were able to do that?
Yeah, no, most definitely. Those are all really great questions, and I'm going to do my best to answer them in totality. So, for us, I really think it starts with those conversations, right? I think when you look across the healthcare landscape and you're talking to primary care providers, right? They're the front lines of mental health care. They're seeing 80% of challenges, from mood disorders to anxiety disorders to substance use challenges. Their patients, those are their patients. And oftentimes, they're under resourced and they're really busy as hell already trying to address the challenges that their patients face. So when we come into the approach with really empathy and trying to understand what are the challenges that you have already, it really becomes an educational process. It really becomes, well, you're having trouble getting your patients into behavioral healthcare resources, right? 50% of folks that you refer to specialty care fall through. And then maybe if they do get to see a mental health provider, maybe they last about 2 appointments, right? So it's really not as effective for their patients already. One of the things that we highlight about the collaborative care program is that folks are getting better outcomes faster, right? Sometimes 4 to 5 times faster compared to traditional care models, because you're meeting patients where they're at. So I think that's really a big part of it. And then coalition building, right? Understanding how can we get groups organized around these challenges. And maybe it's not starting with the model. Maybe it's starting with, well, we don't have enough providers to meet the needs, right, in our state or in our community or in our county. So what are ways that we can transform the resources that we do have or leverage the strengths of our organizations or our counties to meet the need, right? And then you start discussing models. So I think you focus on the need first, and people can get around the idea of challenges, and then you can kind of build conversations from there. But really just identifying key stakeholders and champions within organizations and the larger community in general is really going to be important. Because sometimes we have the same underlying motivation, but we're saying it differently. So I think coming together and really being able to bond over a common goal is important, even before really focusing on the model itself.
That's very helpful. Thank you.
Yeah, and I would just add, I think everything Dr. Arnold and Jason said is on point. And I would just add as well, I think that focusing on the problem is very important. I think it's hard to deny. I don't know many healthcare providers who would say what we have is working. And I think, many of us obviously went into this to try and help people. And when you see that what you're doing isn't working, I think that can be very frustrating. And that's a big portion of burnout that many providers feel. And I think one of the things that we don't always emphasize about this model, but is maybe one of my favorite parts about this model, is the idea that, we can be a part of you helping your patients, and that's gonna, help you feel better about the work you do, right? And I think whenever you introduce anything that's new, it takes time to sort of like process it and think about it. I think luckily there is a lot of weight for the evidence of collaborative care, which can be helpful to physicians, but it's, I think as speaking as a physician, I don't think we're always the easiest. We don't find change the easiest. We're very traditional, but I think just as collaborative care can be successful because it can be high touch because of the behavioral health care manager, I really do think kind of spending time with people, focusing on the benefits of this, there really I don't think is a shortcut for the time. And again, collaboration is a beautiful thing, but the more stakeholders you bring into any process, the more effort and time it will take. But I do think for the groups that have really gotten over that hump and have seen those benefits, they can be examples for everyone else as well.
Those are great points. I want to follow up on something you said, which is change can be really hard for physicians. And I think change is hard for anyone, right? But you talked about a lot of times you're trained in a traditional model. And so for me, I'm curious if you all have any messaging that you think would be helpful as we're trying to talk to people who have been trained in traditional models of care and are used to practicing in specialized behavioral health models of care on where does this fit along the continuum? Because one of the things that I often hear as we're talking about behavioral health integration is that there's some hesitancy on, well, where does this fit and will it take away from some of the current BH services being delivered in specialty settings? So I don't know if you would speak a little to that.
Yeah, that is a very good question. I think the numbers speak for themselves, right? From an epidemiologic standpoint of the burden of mental health that we face in Illinois and Arkansas, across any state in the US, we do not have enough providers in specialty care to meet those needs. So to me, that is somewhat of a non-issue because there's so many patients that need to be served, and we're not doing a good job meeting those needs as it is. And Cyril has repeatedly mentioned this throughout the presentation, is we're not going to train our way out of this dilemma. So we're not going to have enough psychiatrists, enough therapists, right, to meet that need. So this is just an extension of that continuum. We're still going to need psychiatrists independently seeing folks with severe persistent mental illness, folks that need a little bit more support from that standpoint. So that work is going to be there. One of the things that I think is sometimes undersold about this model is it has been shown to increase physician satisfaction, right? And I think we got to think about why that is. You come into this space wanting to care for patients. You come into this space wanting to do good. And a lot of that burnout that people face that results in high turnover of physicians, it comes from that moral injury, right? And that ability not to be able to meet the needs of your patients and feeling under-resourced. The really cool thing about this collaborative care for me as a psychiatrist is being able to be there and support the team, right? Being able to work with the behavioral care manager, being able to help my primary care colleagues when they have a question, and they're super capable and they deal with and treat, mental health really effectively if they have more time, right? So this is just a way to support them, help them feel more comfortable with things, and really be able to address the needs of patients from a population standpoint, right? Which I think is very different from other models of care because we're thinking not just about one patient, but we're thinking how we're managing populations and communities. And one of the things too that this model will offer is kind of those financial and cost benefits that Cyril mentioned, especially for folks who find themselves in value-based care models, because the linkage between mental and physical health is really undeniable. The literature is really extensive that when folks don't have adequate mental health treatment, their physical outcomes there are really, worse, right? Whether that's diabetes management, cardiovascular issues, we definitely have data on all of those things. So, physical health, mental health, I know we like to add those words, before that, but it's all health, right? And they are intertwined and they're not separable.
Thank you. That was extremely helpful. Other questions? this is the time to ask anything you wanted to know about COCM or anything you were wondering. We would love to have our two experts answer.
While people are thinking, I'm gonna ask a question. Since y'all have recently really done a deep dive into what is going on across the country in integrated care, where are the states that are being more successful? Because I'm kind of encouraged that Arkansas, we feel like we're so far behind, um, especially because all the payers in the state aren't paying for it, like Arkansas Medicaid. But I think that's the case in a lot of states. So what are you seeing? We're behind, but we're not, a lot of states are struggling. So what states are doing it well, or have you been able to figure that out?
That's still a process that we're still learning more about, but two of the states that I think come to mind are, it seems that Michigan, through their Blue Cross Blue Shield collaboration with the University of Michigan, the PRISM program, seems that they have many clinics that have been doing this, over 100, I think maybe close to 200. And I don't have necessarily any information on how that's been going for them, but there was that report that was saying that they have seen significant improvements for the patients in the program, and they've also seen, cost savings, right? About 2/3 of what they'd expected over a 3-year period. I also think that we talked to one group in New York, and they noted that they had, I think, around 300 clinics. This was towards the end of last year, that were utilizing COCM. And I actually don't think that was the totality of all their clinics. I think there are different health systems as well. And again, don't have sort of any data into how that's going for them, but the idea that they're continuing to use it and that they're increasing access to care seems to suggest that, it's been successful. There's obviously, maybe not obviously, there's these larger companies, maybe some venture-backed groups who are also doing this nationally as well, and seem to be growing. So there does seem to be, success in different areas. I think what we're realizing, and what we realized both in Illinois, especially and nationally, is there are groups who are doing this that, they're doing it sort of in isolation. So we didn't necessarily know about them, right? But there are clinics outside of the large healthcare institutions in the Chicagoland area. There are clinics throughout the rest of Illinois that do utilize these codes, and there are also states who are probably doing this very well as well, and trying to learn more about where those kind of hotspots are.
Yeah, and I think, looking at, there's good literature and evidence for folks who are in the implementation science space who think about, and that we found in our analysis, when we were looking at what needs to be done within the state, is there are things that need to be changed, right, to allow for this to be adopted really effectively and to see widespread adoption. So one thing you mentioned was like payers, right? So for us coming into this space, one of the major reasons we looked at collaborative care as a model that we want to practice in is that it increased access for the folks who don't have access, right? And for that to happen, it can't just be private payers that are reimbursing for collaborative care, right? You have to be able to engage with CMS and understand, what are the pressure points for them when it comes to mental health care challenges, and how could this model fit within that? One of the spaces or the states that you're seeing some of that work being done in collaboration with Medicaid, Medicare is North Carolina, right? Where they've, looked at reimbursement rates because this is a priority for them to be able to increase access to mental health care, because not having access to mental health care is giving you all types of sequela throughout the community for individuals and communities at large. So there is a lot of work to be done on those fronts. But I think it's understanding where you are. It can always feel like relative to other places, hey, we're not as far. But in some ways, the work that you're doing to demonstrate efficacy within your state is really important, right? ABIN yourselves and UAMS, the work that you are doing with SAMHSA grant to demonstrate how this can really be transformative for groups is really important. And I think is going to lay the groundwork for that success as you all continue to grow.
I'll just make a comment, just a comment that I happen to be the CEO of East Arkansas Family Health Center, but also a primary care physician. And of course, the lack of mental health specialty and patients actually going when you send them. This is a welcome change to be able to take care of folks and kind of puts me somewhat in the driver's seat, but making sure that folks are taken care of. I think it's crucial that, particularly in a health center setting, that there's leadership buy-in, and I happen to be one of the leaders. I won't say the leader, but maybe one of them. But so I think we're excited about working with Dr. Sarah and Jason, and they'll be on site on February 27th, engaging with our providers at the West Memphis site. So I think this is going to usher in a kind of new trajectory of the way we take care of our patients. So I'm excited about, the collaborative work that we'll all do.
We're also really excited, Dr. Ward Jones. I think that was very well said. We're excited to come down there, and we are really happy to have you as a champion for this as well. So looking forward to what we're going to do now and in the future.
Absolutely.
Oh, thank you, Dr. Jones, for coming on and sharing a little bit about your perspective. I know we're at the top of the hour, and I just want to remind everyone that today was just a teaser for COCM, but please come to our conference on April 8th. Dr. Cyril and Dr. Jason will be there in person, and our conference will be focused on the collaborative care model. It's going to be great. We're going to have folks from North Carolina there. They're going to be talking to us about what's happening in North Carolina, how they've gotten to the point they are. We're going to have Eastern Arkansas talking. We're going to have Dr. Jason and Cyril. It's going to be a great day, all focused on COCM. So with that, we thank you for your time. This recording will be on the website, and we'll see you at the next webinar in March. Have a great week. Bye.
Take care, everyone.